Hey, this is Sandy,
And Randy.
and we're here on AT Corner.
Being an athletic trainer comes with ups and downs, and we're here to showcase them all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. For this week's episode, we have an interview that has a lot of heart, especially when we talk about the athlete's heart.
You know, it's really sucky when an athlete comes in with cardiac history, whether that means like family history of cardiovascular issues or hopefully not cardio issues themselves.
Yeah.
But it's really nice when you can actually have someone in your corner who can help you through all that.
It's funny you actually said that because I was going to say this is like continuing our theme of having providers that you're like, I never thought about it, but now I really need one. And obviously we know like cardiology, is a big deal and like we should definitely have a resource for that. But a lot of times it's really hard within like athletics, unless you have like a lot of resources at your disposal to have a good cardiology connection, which on the less severe side of having a cardiology thing, that's usually what it means when you have someone who you're like, shoot, I need to send to cardiology. Oh man, this appointment's going to be fun to try and schedule.
Yeah, honestly, I feel like cardiology is someone who we use so often, but also someone who I don't feel like everyone has, like you were saying, on their medical team. I feel like it's just kind of like, okay, go through your primary care, go through, get a referral, and then it just looks like this long time frame that
I'll see you in 3 months.
They have to do all these testing and hopefully it's nothing. But you have to do the testing because you have to make sure that it is.
What if it is something?
Right.
Yeah. And that is the tough part. And because it is a serious thing, and we want to make sure everything's ruled out and we're giving the best care possible.
So it's really, really nice when you can have an awesome cardiologist like Dr. Brian Becerra. Do you want to introduce him?
Yes. So Dr. Brian Becerra is a board-certified cardiologist with UCI Health. He received his medical degree from Stony Brook School of Medicine in New York. He completed a residency in internal medicine at UC Irvine. He was the chief resident at that time, so that's pretty cool.
That's really cool.
Fun fact. And then next he completed a fellowship in cardiovascular disease at UC Irvine.
So I'm going to steal your pun, and I'm going to say, let's get to the heart of this.
That was good. I like it.
Awesome. Randy, you want to get started?
All right. So at AT Corner, we really like to pair evidence and experience. So if you could provide us a story, maybe a case study about providing cardiac care to athletes.
So I have a decent story, well, more interesting, for my very first patient when I was an attending. So my very first sports cardiology patient, it was early on, which was just a year ago. I was sent in a patient from some athletic trainers and our sports medicine colleagues for somebody who was having palpitations or just rapid heartbeats that they were worried about, mostly when they were doing some strength training. So they came to see me, and I was really excited. I was like, oh, finally I get to do what I've been waiting for. Been some sports cardiology stuff. This is going to be really fun and interesting. By the time they get to me, they're like, oh, yeah, by the way, I'm not having those symptoms at all. And I just asked, what happened? Like, well, I was drinking 600 milligrams of caffeine at the time, and now I've stopped, and I feel great. And I'm like, well, there's your problem. So it was good that it was a simple fix, but it's definitely something that could have been found earlier, but it's a good way to dip my toes into it when it first started.
Oh my gosh, that's pretty funny.
You know what? I got to say, it's kind of like one of those like bittersweet moments, I guess. Is it better or is it worse that they figured it out? Because I feel like a lot of times we also get athletes who swear it's not the caffeine.
Oh gosh, yeah. It's not the energy drink.
I think it's definitely better, and I mean, sometimes it's not, but 600 milligrams caffeine is like 3 Celsius, and they were just like pounding it. So like, it was an excessive amount. And it was funny because they said that their mom talked to them afterwards and said, so it was the caffeine that I told you were drinking so much about. And so, yes, sometimes it is definitely the caffeine. So asking about that, I'm glad he figured it out on his own though, because it's better to than it actually being a real problem.
Right, right.
Yeah, for sure. And it goes back. Probably should listen to mom on that one.
Yeah, good. Told you.
True, but it's hard. It's hard. I mean, when are you going to want to admit your mom was right, especially when you're older? So I get it. So it was easier for them to admit to me than their mom.
For sure. That's funny.
So, in addition to palpitations, are there any other clinical signs or red flags of cardiovascular pathologies that an athletic trainer should look out for?
Yes, definitely. So um, in the sports cardiology world, there's a lot of different things that you're looking for. There is this like 14-point checklist by the American Heart Association that is a good like pre-participation
Hmm.
screening. It's more for the practitioner side because some of it's like physical exam
Mhm.
findings,
Hmm.
but there's still good questions that could be asked by anybody. So, do you get chest pain or discomfort or tightness when you're exerting yourself? It's a pretty simple one that if anybody heard that, you'd be worried
Mhm.
about. Any unexplained passing out or almost passing out. Other things where you have excessive shortness of breath or like the palpitations with exercise. Or other things where you've been told about heart conditions before by other medical practitioners, like prior heart murmur. Do you have high blood pressure? Have you ever been restricted from sports in the past? And have you ever had any prior testing for your heart? So those are some things that you can ask from anybody that should really tune up what if you're worried about heart conditions. But other things that's sometimes often missed is not just asking about the patient's symptoms, but or the athlete's symptoms, but actually their family history. So, do they have any premature deaths in the family from people under the age of 50? Or so like first degree
Mhm.
relatives or anybody with heart disabilities due at an early age or any known cardiac conditions in family members. That asking about family history often gets overlooked, and so it's something that you should never forget about.
What does the follow up look like after maybe some of those history questions? So, what if you have someone that does have like, oh, they had maybe had a family history of uh, a family member passing away under the age of 50, and maybe they are having some of those like chest symptoms. Like, what does that kind of referral and follow up process look like?
So it depends a lot on the system and institution that the athlete is in. Oftentimes, their first point of medical contact is going to often be a sports medicine
Hmm.
doctor. And from there, it will get filtered out to go come to someone like me, the sports cardiologist. But once they do, then there's going to be a lot of different things like testing and other questions and physical exam stuff that we're going to do based off of their symptoms. And those things can be like doing an EKG, which every sports or every athlete that comes by the time they get to me, they're definitely going to get an EKG,
Hmm.
which in the sports cardiology world, EKG screening is a really hot button issue and it's a huge controversial topic.
I bet.
And so that could take a whole other segment. But I mean, it's important. It gives a lot of
Hmm.
information. Um, in the US compared to Europe, it's really a big difference just because the way the healthcare system is set up. But if they're coming to me, they're definitely going to get an
Hmm.
EKG. And other tests that are helpful are things like an echo or an echocardiogram. And lots of people don't understand the difference between the two because they sound
Hmm.
alike. Electrocardiogram or EKG, an echocardiogram or echo. So an EKG is you just put some electrodes on a person's chest and then arms and legs, and they monitor the electrical conduction of the heart system. And that's really helpful because it can also point to other structural signs and problems with the heart. And it's a really easy test to do, but it's really limited. It's really old technology, and so it's a good test, but you have to use it in addition to a lot of other things. An echocardiogram is a lot more involved test. It is using an ultrasound probe to look at the structure and function of the heart. And to do that full evaluation can sometimes take about an hour.
Oh, wow.
And it's using just like a sonogram probe for that you use like for babies when you're looking at pregnant women, but it gives us a lot of great information because we look at the structure of the heart, we look at how well it's pumping, we look at chamber sizes, we look at a lot of things. So most athletes are going to at least get those two tests. Other things are going to also really help depending on the symptoms. So things like a stress
Hmm.
test where we have people walking to running on a treadmill or a bike, and we're monitoring the electrical conduction of the system. So we're doing an EKG at the same time. And we can add other things to that. We'll also add an echo while they're doing the stress test. Um, but that's really good because we can see what actually is happening with the athlete's heart while they're exerting
Hmm.
themselves. And so that's a really, really useful test because it can show us a lot of different things about their heart and conditions that sometimes only come out when people are
Hmm.
exercising. So stress tests are really helpful, not for the same reason we use stress tests in older populations looking for blockages in the arteries in the heart, but it can for specific symptoms. But other tests that we use as adjuncts too are something like an event
Hmm.
monitor, which is like a little patch monitor that people wear that they can wear for 2 weeks, sometimes up to a month, where it's like a mini EKG during that entire time. And it's looking for abnormal heart rhythms and what the heart rate is doing throughout those 2 weeks. And what's really nice about that is that you can have that on while you're exercising or doing your sport. The problem is, and I ran into this recently, is that you can't get it fully submerged in water.
Hmm.
So any of your athletes that are in pools, so like swimmers, water polo, anybody that's going to be submerging themselves in water can't use this. And so if they're having palpitations and they're going in water, you got to try to work around it. There's a lot of other tests. There's another test called a cardiopulmonary exercise
Hmm.
test, which most people kind of know about. Like you see commercials where athletes are wearing like a big mask while like on a bike or something with a bunch of tubes and something to monitor VO2
Hmm.
max, which is oxygen output from the body's muscles. But it's also good to evaluate a lot of other things that can be problems with the body. So it is also helpful. But there's so many other
Yeah,
tests. There's MRIs of the heart, there's CT scans, there's a lot of different things that we can do that's going to really be tailored to what is actually going on with the athlete.
are there any specific like lab work, like any like blood tests that like we could probably prep the athlete, like, hey, you might be expecting this within that follow up?
Mhm. I think we would typically do basic
Okay.
labs at least, so like a basic metabolic panel, look for at CBC or a complete blood count, but also looking at for their thyroid
Hmm.
function because abnormalities in the thyroid can cause abnormal heart rhythms. If they're going to be coming to me because I'm on top of just being a sports cardiologist, I'm a
Hmm.
cardiologist. So I always will also look at their lipid
Hmm.
panel and look at A1C or the blood marker for sugar or diabetes. Because if you do have conventional risk factors for heart disease, that's going to put your risk into a different category than if you did. So most of the time, it's going to be pretty basic lab work unless something specific is going to trigger us to do other testing. So other things can be, but this would typically be farther down the line, would be something like genetic testing, where you have to send in a swab to look for different genetic problems, channelopathies, a lot of other things. So it really depends, but they likely are going to get some sort of blood work by the time they are coming to see me.
For sure.
With sport athletes, do you find that you are running um, certain tests more often than others? Like, are you seeing like um, a, a trend in some symptoms that lead you to go more echoes or stress tests or something like that?
I think so. Yes, I think with athletes, so the majority of the cardiology population that I'm seeing are older
Mm-hmm.
individuals. So I do see a lot of younger people, but a lot of younger people who are not athletes, I'm seeing for other specific things. For athletes specifically, I'm going, especially on the younger end, I'm going to typically have them do a stress test,
Mhm.
which for most younger patients, you're not worried about doing a stress test since we normally do stress tests looking for big blockages in the arteries in the heart.
Mm-hmm.
So if you're younger, oftentimes that's not a problem, but there are abnormalities with the coronary arteries, that something like an anomalous coronary artery where the artery that feeds blood to the heart muscle comes from a different spot that can be
Mm.
dangerous. That can cause similarities like big blockages in the arteries in the heart. But yes, I typically am going to do some sort of stress test for other reasons, because lots of times these athletes are getting their symptoms while they're exerting themselves. So if I don't exert them, then you may not see it.
It's actually really fascinating about the Halter, or is the test you were talking about the Halter monitor that can't be submerged?
So yes, similar. So Holter monitor is an older system where it's like you had to put a lot of electrodes and you had like this big battery
Mm-hmm.
pack. The one that we use the most often is something called a Zio
Oh,
patch,
okay.
which is like a little monitor that you could wear. But there's other ones that are similar. There's Cam Patch, Life Watch. There's a lot of other companies, but they're all just like little sticky like plastic things that's like the size of a flash drive that's just on their
Oh,
chest.
that's
Hmm.
cool.
Is there a way you've gotten around for swim athletes?
For the most part, it's either I have to try to catch them in between their season,
Mm-hmm.
or there's other things like there is things that you can buy, something like the Cardio Mobile device, where it's like a little tiny metal contraption thing that you put your fingers
Mm-hmm.
on, and it does a mini
Oh,
EKG.
Mm.
So
crazy.
you can have them do it in between when they're swimming,
Mm-hmm.
and so that will give us a similar information. Not as good, but it's still pretty good. This is something that anybody could buy, and you could get them even like on Amazon.
Hmm.
So sometimes I ask them to do that and then bring the strips in.
Actually, it's funny you bring that up because I can't believe I forgot about this. But the EKG on the Apple Watch, like how,
Mhm.
from your experience or maybe
Yeah.
some of the evidence you've seen, like how valid is that kind of measurement?
So it's hard. It's good. It can give us a lot of information, but the problem is that, so it's not just Apple Watch. There's You
Mm-hmm.
could do it on Samsung watches, on like Garmin's, on so many different
Mm-hmm.
things. And so it is helpful. It's really good for especially getting heart rate,
Mm-hmm.
obviously, but the mini EKG portion can be helpful, but I've seen it backfire several times where if they have, say, like a lot of extra beats from the top chamber of the heart or the bottom chamber of the heart, something either called premature atrial or ventricular contractions, where the Apple Watch will call it something like atrial fibrillation, which is a big abnormal rhythm that we have to do a lot of things for.
Mm-hmm.
So it can misdiagnose things sometimes, but it is a good tool to at least tune you up to say, maybe I need to do more
Mm-hmm.
testing. There's other things about there on the watches which are really hard, and especially because a lot of the algorithms they use are proprietary, so we don't know
Uh,
exactly what's going into it. But things like the heart rate variability and some of the other things that they have within the watches, it's a lot of times hard to use that data by
mm.
itself.
That makes
And so
sense.
you can use it, but in conjunction with other more validated tests.
Got it. Okay. What I was going to ask also was, during this time of testing, and like it may depend on the symptoms, but what kind of activity modifications might you be putting in there for the athlete?
So it's really going to depend on the athlete and what's going on, because every single abnormal heart problem has a huge spectrum,
Mm-hmm.
and so lots of times you don't know what's going on up front. So it's really going to depend on the athlete, but it's not just the athlete. It's going to be talking with you guys, athletic trainers, with the coaches, with some oftentimes their parents if they're young, with the sports medicine physician. And so it really is going to depend.
Mhm.
If it's an athlete that passed out with a family member who died at 35, and you're going to be worried,
Mhm.
and maybe you have to hold them back, versus somebody who's getting a little bit more short of breath recently, but no family history. They just had a cold or something. So it's really, really going to
Mhm.
depend on each individual patient.
Got you.
Blanket statements are hard to make
Mhm.
in athletics.
Yes, definitely. And even amongst athletes with the same thing, it's tough.
Yeah, we have a really fun saying, especially like sports medicine or just athletic training in general. The answer tends to be it depends.
It depends.
Which is true, and that is a great saying.
So your answer might be it depends for this one, but I was wondering, you were talking about looking at heart rate as well. How much are you actually looking at heart rate, and can it be a standalone factor that you're worried about, or is it something more like in general
You're
along with
thinking
other
about.
things?
So it can. So it depends. So yeah. So it's by itself. So there are conditions where just heart rate is a problem, and so not
Mhm.
even with abnormal heart rhythms. There's things. There's something called inappropriate sinus tachycardia, or something we're seeing a lot more. Something called POTS, or postural orthostatic
Mhm.
Mhm.
tachycardic syndrome, where the heart rate, but especially inappropriate sinus tach, where the heart rate itself is a problem, but it can often be an indicator of other things going on. So you have to really make sure that you look for the other things first. And then if nothing else comes out of your testing, then you can focus on just the heart rate. And the heart rate changes a lot with athletes, especially, but with everybody, with conditioning, deconditioning, if they're in their season, not in their
Mhm.
season. So it really is going to depend.
Kind of along the lines of heart rate, what role does blood pressure play in that? Because during like pre-participation exams, right? Sometimes we'll get like some athletes where they're like blood pressure's like over 130, over 140, and that's not ideal. At what point is that kind of like, hey, this is a red flag? Like there might be a concern here.
So it's always something that you should think about, and it really depends on the sport too, because like a power lifter versus say a track
Mhm.
runner, or somebody running a marathon, or a football athlete, like it's going to really depend on the sport that they're doing. But it's also important to make sure that the blood pressure is being taken right, but not just taken right, but in the correct setting.
Mhm.
Because if you take a blood pressure right after an athlete exercise, it's going to be higher just from the exercise. Or if you're doing it all in a pre participation screening, you want to make sure that it's not just somebody rushed into a room, then they take the blood pressure and then kick them out, because then it could be high.
Mhm.
And I see that all the time. And it could just be high also. Something that we see all the time as a doctor is something called white coat heart hypertension, where their blood pressure goes up just because they're being monitored there.
Mm.
And so if you see that, you really should um, at least caution them to think maybe you should be checking your blood pressure at
Mhm.
home. And then if you start to see that it is actually typically high, then you got to talk about at least sending them to a physician, even the primary care, the sports medicine doctors, to see if it needs to be treated. Because if your blood pressure is starting out high before exerting yourself, it can definitely become a problem.
Got you.
What are some common cardiovascular pathologies that athletic trainers should be cognizant of?
So there's a lot. Went did a whole fellowship on just cardiac diseases, but so there's a lot, and it really depends. So there's problems with the heart rhythm, which is an electrical problem. Um, so there's the abnormal conduction problems, arrhythmias. There's a lot of different things like Wolf Parkinson White, long QT. There's a lot, like a million different things from the electrical standpoint.
Hmm.
But there's also problems with the heart muscle itself, where it's too thick.
Mhm.
So things like hypertrophic cardiomyopathy. And there's a lot of other things like channelopathies, and there's
Mm.
things that you should be worried about. But it's such a huge variety of things, and one pathology doesn't necessarily um, present itself the same way.
Mhm.
Mm-hmm.
So one person may have palpitations, the other might have shortness of
Of
breath,
course.
and so it's hard to just say specifically on the symptoms itself. One of the biggest and most worrisome diseases that we see in sports cardiology is something called arrhythmogenic cardiomyopathy. It used to be called ARVD, or arrhythmogenic right ventricular dysplasia, or ARVC, arrhythmogenic right ventricular cardiomyopathy. They're all the same thing, um, but it is an abnormal problem with the heart, and it's normally a genetic mutation. And the biggest problem with it is it's one of the only pathologies that exercise makes it worse.
Oh.
So even with all of these other medical conditions with the heart, things like lots of people hear about hypertrophic cardiomyopathy, but depending on a lot of different factors, there's players in the NBA with hypertrophic cardiomyopathy.
Okay.
Hmm.
But arrhythmogenic cardiomyopathy is really one of the most worrisome diseases that exercise, and especially things like really like marathon running, and a lot of exercise and training can make this condition worse. And so it is something to that we really get worried about, but we have to really make sure that it is the actual diagnosis, because it's a big deal for us.
Are there any other kind of cardiac conditions that may disqualify someone from sport, or at least start the conversation of we might have to like maybe modify the sport you play?
So yes, there's a every condition can, because all of them are on a
Okay.
spectrum. So well, not every
Mm.
condition, but most of them can. And we in the sports cardiology world just had some new guidelines that came out recently, earlier this year. That's a long name for them: clinical considerations for competitive sports participation for athletes with cardiovascular
Oh.
abnormalities. Scientific statement from the AHA. So it's long. When I'm looking it up, I just Google sports cardiology guidelines,
Uh-huh.
and so it is a lot easier to remember. But these came out earlier this year, and they're a set of guidelines to kind of help you make these decisions in a lot of these different conditions. There was some guidelines a long time ago, like 10 years ago, that now one of the biggest things that's emphasized in these new guidelines is something called shared decision
Hmm.
making, where it's a conversation,
Mm.
not a blanket disqualification, where you have to have a shared discussion with the cardiologist or the physician, the patient or the athlete, oftentimes their
Hmm.
family, the athletic trainers, the coaches, and then not just the coaches and the athletic trainers, but you got to talk with the whatever entities like a university or organization is a part of it, that they are a part of. So it is a big conversation, because there's been times where there's been athletes that will say in college basketball player, that at one school disqualified him, even though there's a cardiologist that said they probably could if you did this and this, but the school disqualified
Mm.
them. So they went to a different college who allowed them to play with all these precautions.
Mhm.
And so it is hard to, again, make those blanket statements. Um, and it's really going to be a bigger decision where it's a conversation, and making sure that you have everything in place to make sure it's as safe as possible, but that athletes can still, if they're understanding of what they are going through, can still participate. But it is a very big conversation with a lot of different people.
For sure. And I feel like that's where sports medicine just in general is heading, is it's a lot of emphasis on a shared decision making process.
Mhm. Which is good. I think it is.
Yeah, for sure.
Yeah, I agree. Can you speak a little bit more about POTS, what you mentioned earlier?
So POTS. So I am seeing a lot of POTS, not specifically in athletes, and now it's hard because it's really You see it a lot as like a big TikTok
Mm-hmm.
diagnosis or Instagram reels, and people are coming in thinking that they have it, which they may not. But it's definitely real,
Hmm.
and not everybody who thinks they have it has it. But it when they do have it, it sucks. It really can be debilitating. We're seeing it a lot more nowadays, because for some reason people with, say, long COVID are getting POTS.
Ooh,
Mm.
interesting.
So sometimes COVID is setting off POTS. And so it's postural orthostatic tachycardic syndrome. And it's when people stand up, their heart rate goes up, but not necessarily with a drop in blood pressure, which would be normal, but also symptoms with those changes in positions. And a hard thing to treat. Oftentimes, it's just a lot of fluids, electrolytes, compression socks, some physical maneuvers, and then making sure that they're staying upright and exerting themselves, because deconditioning by itself can definitely cause changes, big fluctuations in heart rates. And there are some medications, lots of them don't work the best. Some people respond better to others,
Mhm.
but it is a tough thing to treat. But you really, it's hard because I see a lot of people diagnosing themselves with it. You really need something called a tilt table test
Mm.
to confirm it. Um, but it is tough, and we're seeing it a lot more.
Do you have any recommendations for athletic trainers to look out for or to help manage POTS in like an acute setting?
So water and salt is often going to be the biggest thing. So all my patients with POTS, I tell them they need to drink at least 3 liters of water, which is 101
Mhm.
ounces a day. If you're an athlete, probably even
Mhm.
more. This is for patients who aren't exerting themselves that
Mm-hmm.
much. And a lot of salt or electrolytes. So I recommend 8 to 12 grams of salt a day. The average American salt intake is about 3.5 to 4
Oh wow.
grams. So, like 2 to 3 times the amount of salt that the average American is taking in. And it's hard for a lot of these patients because it's they don't know how to get that much salt in, and it takes a lot of different things, like electrolyte packets, things like liquid IV, or there's these drops like something called buoy drops that I have a lot of POTS patients like. And what's good about doing things that you could put in water is that you already should be drinking a lot of water.
Mm-hmm.
Mhm.
So instead of just adding a lot of salt to your food, um, adding things to things you're already doing are good. But I have had patients just drink straight pickle juice because they like it and it has a lot of salt. But other things like, I mean,
Mhm.
Gatorade, Powerade, sports drinks, but making sure the ones that don't have too much sugar. So if in an acute setting when somebody's having actual POTS symptoms, you really should be just taking them up with a bunch of water and salt, and however you get those electrolytes in, and that should help at least when it's going happening.
Awesome. Yeah, I've had a couple athletes with that, especially in the last 2 years.
Interesting.
I feel like I've had uh an uptick, it seems like.
Yeah. Yeah, no, same. I think we're in general seeing it more, probably recognizing it more, but I think it's harder in athletes. But it's also, I see it a lot in patients who just are deconditioned, and
Mm.
so
Mhm.
that makes it a problem too. Because when you're deconditioned, and I tell a lot of my patients, if deconditioning is basically just the heart is out of shape, and what happens when that happens, when you're deconditioned, is that your resting heart rate is higher, and any little exertion, so just getting up and walking to out the door, can cause your heart rate to pop up really quickly, and that can definitely make all symptoms worse. But I'm also seeing most people are really dehydrated, which will exacerbate that on top of it. So it is hard, to to make sure that patients actually have POTS. But all the things that you're seeing, it's definitely coming out a lot more recently.
How often are you seeing athletes who, or even maybe general population, who seem to have heart symptoms, but it's actually more like mental health symptoms?
A lot, and so it's not just athletes, but I see it a lot of times, and most of it is most of my general clinics days. A lot of the times, it's me just being like a therapist,
Mhm.
and it's really talking people through, because a lot of people are saying, "Oh, I get palpitations every time I'm anxious, and I'm anxious all the time." And it's like, well, it's not a heart problem; it's an anxiety
Right.
problem. And so, really talking people through that is tough, and it's hard too when you have really busy clinic days when they really just need hours of talking and
Mhm.
therapy. And so it's hard, and you have to do what you can. But I see it a lot.
Hmm.
I definitely see it a lot.
Is there a way that we can help identify easier between the two?
It's hard. It's going to be
Mhm.
hard, because you don't want to misdiagnose something real for anxiety.
Mhm.
Absolutely.
And sometimes I had, when I was in residency, this ICU attending that would say that patients with shortness of breath, sometimes their first symptom is anxiety. And it's not because the anxiety is causing shortness of breath, but them not being able to breathe is making them
Mhm.
anxious. And so it's going to be hard, and you're going to have to still make sure you're not missing anything, because you don't want to miss big
Yeah.
things. So it's better to err on the side of caution than to just chalk it all up to anxiety.
Absolutely. It's also uh, uh, fortunate enough if you're able to, if you have a good support at your
Mhm.
institution or wherever you're working to just address both.
Yeah, definitely. And it should be addressing both. I mean, I think it's hard. I mean, mental health in general is a tough subject, and a lot of things that the athletes, patients don't want to address themselves.
Hmm.
And so it's just they should be addressing both, I think, and you need to make sure you have a system that could support that. And it's just hard, and sometimes it's not even the system; it's the patient's insurance, or
Hmm.
just a million other things. So it's tough, and it's not something that you're going to be able to fix on your own.
Yep. And those million other things cause more stress.
Yep.
Yeah, exactly.
Just insurance
Yeah,
can cause
honestly.
stress.
Oh, oh my gosh, you that's the so much of my day is just calling up insurance companies, fighting for tests and stuff. It's
Oh,
just unbelievably tough to deal with.
that's
I
hard.
believe it.
Yeah.
It's rough.
Another cardiac condition for you. How many times do you come across? I think it's called G6PD.
Not often, almost never. I learned about it in medical school, so it definitely is a thing,
Mhm.
but no, it's not common at
I
all.
had one athlete with G6PD, and I had never heard of it. He collapsed on the football field, and I was not sure if he was trying to tell me the name of an airplane or like I literally had no idea, and I was like, okay, let me look into this.
Yeah, it. I learned about it in medical school. G6PD deficiency. Like there's a lot of buzzwords in med school, and it's like fava. If they're eating a bunch of fava beans, which I don't think I've ever seen a fava bean, but can make it worse. And so there's it's a thing, but it's not that common. Not that I haven't seen it, but I know of it.
Yeah, there's always gonna be
So
something, right?
Yep.
so it was a real thing. He wasn't. He was telling you something
It
real,
wasn't
but
an airplane.
it's not.
Yes.
So speaking of that like collapse, a sudden collapse, one of the big concerns with that is the possibility of sudden cardiac arrest. And the overall goal of the pre-participation exam or trying to get ahead of some of these conditions is preventing that. So how preventable would you say sudden cardiac arrest in sport is?
So it's definitely not 100%
Hmm.
preventable. It You can help prevent it by doing all of these things, where you're doing all this pre-participation, making sure you have a great emergency action plan, making sure everybody knows CPR, all the things are in the right places, you know where the AED is. But it's never going to be 100% preventable, but it should be 100%
Hmm.
actionable, where you should be, if it does happen, you should 100% of the time be able to act on it. And so it's a problem because there's a lot of cardiac conditions that come up that you won't get screened through any of these, um, any of what we're talking about. And sometimes like it's they're the first person in their family to have a problem, and so you aren't going to necessarily be able to catch
Mm-hmm.
everything. I mean, the good thing is that sudden cardiac death has over the years definitely come down. The incidence of it has definitely decreased. Um, and so there was a study, I think it was a couple years ago, looking at it was a 20-year study on looking at sudden cardiac death in collegiate
Mm.
athletes.
Mm-hmm.
And like half of the deaths were accidents, and then the next biggest thing that people died from was cardiac arrest. And then the other things like suicide,
Mm-hmm.
homicide, those things came out after, but they were still a big portion of it. But within that population, the biggest of those athletes that died from sudden cardiac arrest, the biggest portion of them that passed away were due to something called autopsy negative sudden arrest.
Mm-hmm.
And so it's something that even on an autopsy they didn't see. And it it could be from channelopathies, it could be from a lot of other things, but there's things that you could be completely healthy and have something like commotio cordis, where
Mm-hmm.
you get hit in the heart in the exact right place, the exact right strength at the exact wrong time, and have cardiac arrest. And so you can't prepare for
Mm-hmm.
that beforehand because it's just unlucky. But you should be able to respond to
Mm-hmm.
that. And so do everything you can beforehand, but hope for the best,
Yep.
prepare for the worst. So make sure that you're ready for when it does happen. But it's also important too that I know you guys are athletic trainers, and it's good to that there's going to be athletic trainers at all of these
Mm-hmm.
events, right? And so you should have emergency action plans. You should know CPR, BLS, know who to call, 911, all these things. But it's also good that I don't think happens all the time, and it should probably come from you guys, the athletic trainers, talking to the athletes themselves, because the worry isn't that, oh, if somebody in a big game has a sudden cardiac arrest, you trainers are going to know what to do. You're going to go make sure that they're actually having cardiac arrest, then do CPR, AED, call 911. But what happens if that athlete actually collapses when they're out practicing with their friends when you guys aren't around?
Mm-hmm.
And you want to make sure that your athletes are prepared for those circumstances because they're off training and doing stuff without you guys. And so teaching the athletes themselves when to recognize cardiac arrest, what to do, like just hands only CPR and calling 911, because sometimes they won't know where an AED
Mm-hmm.
is. They'll be confused. If they know what an AED is or know that there's something available, that's even better. But just understanding and teaching them at least CPR is good, and how to recognize it, because it happens and they're going to probably be without you guys training more often in their life than not.
Mm-hmm.
So it's good to impart on them to look for it as well.
Sure, I like that. That's really awesome.
I really like what you said about it might not be 100% preventable, but it should be 100% actionable.
Yeah, I am, which is hard, but it should be. It definitely
Right,
it
right.
should be, and that's why we're doing this, or why people are preparing. And you should definitely prepare
I
for
would say that could be the
it.
quote right there.
Mm-hmm.
And
Do you want to get on our action item?
Yeah, go for it.
Perfect segue. So here on AT Corner, we also like to kind of wrap things up with an action item. Obviously, there are so many actionable steps that we
Mhm.
can take from this podcast, but we kind of just like to wrap it up, kind of like a clinical bottom line. Um, our action item today is: what advice would you give the athletic trainer who is looking to add a cardiologist to their sports medicine team?
so I would say first talk with whatever regular sports medicine doctors that you should probably already know or be in contact with. They should be the first point of contact, and then they oftentimes will know cardiologists around the area. But if you want to go straight to cardiologists, even just Googling sports cardiologists in my area is good. Sports cardiology in general is a small field. It is very small, but it's growing. And there are a lot of cardiologists that focus on sports medicine, which is important for you guys because sports cardiology is completely or is very different than just general cardiology. But I think working with your sports medicine doctors themselves to then branch out to a sports cardiologist is a good idea. But also just looking into sports cardiologists in your area. And even if that's just Googling sports cardiologist in my area, because you'll be surprised, and it depends on where you are in the country. Lots of times universities, academic centers will have somebody that is doing something in the area. So that's a good place to start is to look for local university hospitals. But there's a lot of great sports cardiologists in the country that aren't affiliated specifically with a university. So even just Googling it is a good step. But I think also involving your sports medicine colleagues because they'll often know more and have a better understanding of the doctor relationships in your area.
Got it.
Awesome.
Perfect.
Well, this has been so awesome. Thank you so much.
Yeah, no problem. I was happy to be on this. It's exciting. Thank you guys for definitely having me and some great questions.
I appreciate it. No, thank you so much.
It's so nice to be able to sit with a physician and kind of discuss, one, their expertise area, but two, just also a review of, the different, even the different tests like EKG versus echo, things that like we hear all the time, but they are seeing and ordering and reviewing and whatnot on an everyday basis.
Yeah, absolutely. And I think too, what I really liked with our conversation with Dr. Becerra was being able to kind of get the information so I know how to like kind of guide our student athletes on what exactly could you expect in a visit, or also what questions that, hey, maybe the athlete should kind of bring up, especially if you're not in a position where you can be there with them to advocate. Also, too, the different type of techniques, because I know in my experience, I've had a lot of athletes with halters.
Yeah,
and
right.
it seemed like he kind of talked about how we've moved past the halter and we have better things now. Because, yeah, I feel like a lot of my student athletes, not that long ago, like less than 10 years ago, like they were doing like halters.
Yeah, you had a lot with halters.
There was a span, and it ended up being all my cross-country kids. Go figure. But yeah, so I thought that was really interesting just to kind of see like where we are today and for like that kind of like real-time monitoring. So I thought that was pretty cool. And also too, we got to talk about the EKG on the Apple Watch. So yeah, that was fun. I know I like mine. I have a good time with it.
More data.
Yep, I'm big data here.
Well, cool. If you liked this episode, we do have more interviews coming out soon, especially thank you to UCI Health for providing us so many great physicians to interview. We also have other types of episodes here on AT Corner. So if you're interested in athletic training CEUs through the BOC, we do have some category A CEUs. Thank you so much to our partner, Clinically Pressed and Athletic Training Chat. Both of them have helped us turn our episodes into CEUs, the ones that Randy reads a ton of research articles. We synthesize that information, or he synthesizes the information, then we talk about it in a conversational format, and then for your listening pleasure, so we can turn those into CEUs for you. If you're interested in those, head over to our Instagram for a tutorial at AT Corner Podcast. We also have story episodes where we bring stories from athletic trainers surrounding a highlight topic, and we all share our experiences so we can help bridge that gap between evidence and experience. So thank you wherever you're listening from. We appreciate you guys tuning in, and we will see you next time.
Thank you for helping us showcase athletic training behind the tape. Bye.